Thank you, Dr. Nagarjuna and the team for the kind invitation. EBUS needles. So from the time the EBUS has come into the market, the EBUS needles underwent a lot of research. There are many theories, many things regarding this. Many people ask whether they different, are they same. New technologies are coming regarding their size, regarding the needle tape, regarding the material which we are using. But we are going to discuss about all these things now. So first of all, we'll start with the needle tape. The different companies have different types of tips. The Olympus, which has basically manganese tip with a side holes. You can see the first diagram. Manganese tip is slightly different from other cylindrical tip because it is a tapered bevel edge that facilitates the tissue being withdrawn into the lumen. Another tips are cooked manganese tip with core trap. If you can see, there is a at the around 2 centimeter, 1 centimeter, 0.5 mm, there is a distal cut section which basically when being withdrawn cuts or sheaths the tissue. That is why it is called a core trap. Boston specific, they come with a Frentzen tip, and Medtronic comes with a fork tip which is basically available in the EUS. We will discuss about the Frentzen tip, which is basically 3 prongs that increases the overall cutting surface. These 3 prongs are symmetrical and they cut the surface in a cylindrical fashion. So that's why they give a continuous tissue cylinder like a structure which is basically called as a core tip. And that is the beauty of the Boston Scientific or this Frentzen tip. Other thing which is important is needle material. If you see the different material which is available is nitinol, cobalt chromium and stainless steel. The nitinol, which is basically an alloy of nickel and titanium, which has a shape memory effects and being used in different metallic stents also, and it is 10 to 10 times more flexible than your stainless steel. The Olympus needle is made from the nitinol. Then the cobalt chromium needle, which is opposed to stainless steel, enhances ability to penetrate through the stiffer tissue, and that's why you can use it for multiple passes. The Boston Scientific marketed through as a high grade material, and with you can take the multiple passes or can be used multiple times in India. And the stainless steel is basically cooked and the old Olympus. If you see the angulation of these all these needles, when you are using an EBUS without needle, it has a 90 degree of angulation. You can angulate at 90 degrees. But if you are using the needles, the angulation decreases because the stiffness of your needle. The oldest one, the 22G and 21G Olympus Vigishot, had an angulation of 65 degree and 45 degree. But as the size of the needle increases 19G, you will see that angulation should decrease. But Olympus has come with the Vigishot 2, in which they have given some laser angulation at the distal end. Because of that, their angulation is much better than their previous needles. Boston 25G is a smaller lumen or smaller barrel needle, in which angulation is only 58 degree. And the Core DX, which is not available in India, but in the outside market, the angulation is good, is around 85 degree. This is just a diagram to show you the different angles of these needles. And this angulation matters when you are going into the 4L lymph node or when you are trying to approach in the right upper lobe. This is just a brief diagram to show the angulation. Then another thing which is important is needle trajectories. The needle trajectories is totally different from needle angulation. Needle trajectory is basically at the angle which needle is going to pierce the bronchus. So if you see this first diagram, it is a flex 19G needle which is coming through the riboscope, and another is 21G Olympus needle. If you compare in the third diagram, the angle at which it is coming, or sometimes these angles matters when you want to pierce a specific area in lymph node. When I am seeing some any necrosis or anything, I want to pierce the specific small area, then these small things matters when you are doing a lot of EBUS, or you just want to specific in your diagnosis also. So if you have a stiffer needle, then chances you may have difficulty in passing at the corners at the 4L or maybe the upper lobe, and sometimes when anatomy is also distorted. But when anatomy is good, these things doesn't matter, but when it's difficult times, these things matters a lot. So needle size, does size matters? Let's decide about this. So the first needles which came into market was 22G, which was the oldest needle. Then after that 21G also came. Both does not have any significant difference. The diagnostic yield of 21G was slightly higher, 96.6, and 90 compared to 22G, which is 95.3, but the p-value was almost the same. Still, the researchers says that 21G gives better characterization of non-malignant disease and histological preservation of malignant disease. And I suppose they have, run the market for a long time and they have dominated it. And 21G is the most common needle which is being used. After this systemic review of 15 studies in sarcoidosis and lymphoma, both of them show that variability or the diagnostic yield of these needles was not as more than 95% or 100%. That's why different researches came and new needle came which is called as 19G. These 19G is marketed by all these people as a histological needles. 21G and 22G, they are marketed as a cytological needles. So Vigishot 2 Flex 19G 2015 it came. What is the advantage of 19G? It gives as a lumen which is a more broader. That's why it gives more bloodier sample also. So some people advocates that this 19G gives more bloodier sample because it takes out more of blood also. And diagnostic yield compared to 19G was 21 or 22G is almost similar. So they say 19G achieve more tissue, more tumor cells, but the diagnostic yield is same. But now the time has come when our oncologist demands about the molecular testing. They don't want this type of cancer, they just want malignancy. Just please send it to NGS panel and we will decide which are the markers which are positive. They don't want to subtype as subsquamous, small. Just after the biopsy, they just want NGS panel. So if you have more tumor cells, more DNA, then they can run better NGS in these cases. So in another study, what they have shown in sarcoidosis and lymphoma, the diagnostic yield was higher, but p-value is not so high. If you compare your 25G needle, this is the recent needles which has experienced more in GI literature. If you compare your 25G needle with the 22G, the specificity was almost similar, but the sensitivity of diagnosing malignancy was higher than 25G. It can be better because of the smaller lumen, the bloody aspirates are lesser, so your pathologists are able to give a better diagnostic value. Plus the 25G has a greater needle flexibility. So where is a difficult situation, you are not able to reach the lymph node, you are not able to curve your EBUS, there you can use a 25G needle. So if I say ki 19G better or your 21G is better, it depends on what type of patient you are going to do the procedure. But 25G is vulnerable to clotting because of this smaller lumen. In these cases, you can just, they say you can do one thing is with a stylet, you can just wipe it with the heparin after each use, and heparin does not affects your any cytological or histological analysis also. Another issue which comes with the 25G is there is a discrepancy between the rows and the cell blocks. In one study, what they have found, in rows, they are able to establish the malignancies 100% of the cases, but only cell block in 81% of the cases. I really don't know what is the reason behind that, and they also have not quoted. So almost I have answered. I think everybody should answer the correct answer in this. So find out the best statement. I have tried to confuse you, let's see. Thank you. So these are company-wise. Olympus, which is an older needle, is VigiShot. This is a diagram which is shown. 21G and 22G were available. VigiShot 2 is 21G, 22G, and 19G. In VigiShot 2, I have already mentioned this. They have given the spiral laser cuts on the needle surface, which increases the flexibility plus increases the ultrasonographic needle visualization when you are inside the lymph node. 19G gives amount of tissue, but diagnostic yield is totally different. This is a needle diagram with a stylet knob or needle slider. I think we will discuss about all these things in the workshop. Needle adjuster. The length of the needle, which is important here, is this point. If the needle length can be 5 centimeter or 6 centimeter, depending on the type of the manufacturer, and sometimes the distal the length or the more the length, you can reach the distal area beyond your airways also. This is the rotator sheath. Almost all needles have the similar diagram, but in some they have a rotator nib, sometimes they have a clutch, sometimes, and here also needle adjuster also different. And this adapter is also different for different companies. Now everybody is coming so that they can fix into Olympus, Pentex, Fujinon. Everybody has different mechanisms. So needles have also, they have modified themselves so that they can be used in different scopes. Boston specific 22G, 25G, these are made of cobalt chromium, better penetration. And this Frenzen needle tip has a 3-way cutting surface, which is more symmetrical, gives greater control over the puncture site. Plus, they have shown, because of their puncture site is much better than the other needles, this is a shortened procedural time and less time spent on failed passes or exchanging the needles also. Boston, this is a core tissue which has been brought to the acquired needle from the Boston. This is how beautifully it comes, and luckily there was no blood in this. And core needle, Frenzen tip type, this is the new needle which they are marketing now, and they have shown the yield is almost similar to the other needles also in with GI. And another study on EBUS, they have shown the core biopsy was seen in 87% of the patient, and pathological yield they are able to mention 97% of the patient, and there is no side effects. Another is your Cook Medical needles. These are TABNA and FNP needles, 22G and 25G. These are pro core needles. These are also samples because these are basically marketed as a histology needles. They give better samples. Core trap we have already discussed, which helps in acquiring more tissue and better your diagnosis. This is basically a core trap which is at the distal end around 0.5 mm to 1 mm. These are 22G, 25 reverse barrel, which helps in diagnosing your tissue. Plus, in retrospective study of 125 patients, core biopsy had higher sensitivity than standard EBUS. But another study which was done at Chandigarh by Dhuria and et al., they have mentioned that EBUS DNA in sarcoidosis cases almost same similarity. And they also mentioned there are 2 incidents of pro-core needle getting bent also. Use of suction and stylet, there are a lot of research regarding this, but EBUS TVNA with or without the application of vacuum suction does not influence the specimen adequacy. And one more important thing is that in these cases with suction, you will get a more sample, but the diagnostic yield is totally different about what are the quantity of the sample you are getting. Like when we get good sample, my technician will say, oh sir, the sample is very good, your diagnosis is confirmed. That is totally different from your diagnostic yield. If you are using the stylet or not using the stylet, it depends. Sometimes the people do use a capillary suction technique in which they just take out the stylet slowly and slowly. That also gives you a almost similar diagnostic yield compared to if you are using the suction also. Suction will definitely give the amount of the tissue or amount will be better, but the diagnostic yield is similar. This is another study in which the use of suction or non-use of inner stylet does not make.
Loveleen, you have 2 more minutes.
Yeah, just I'm finishing. Does not make a significant difference in cytological specimen adequacy, and no stylet procedure decrease the basically average procedural time. This is the advantage if you are not using the stylet. Fanning is another method which you can use to acquire more tissue, and US FNA they have shown, I'm just going in a hurry, US FNA is giving more sample in pancreatic lesion, but there is no study in the EBUS. Length of the needle we have already discussed. Number of aspirates, better to get 3 numbers of aspiration per lymph node. This is the future concepts are intranodal forceps, mini forceps biopsies, cryobiopsies, which will be discussed in future classes, and through the needle microforceps and CLE are the future things which may give a better result. This is just a case of a broken needle in which we were doing a simple sarcoidosis patient, we were doing a EBUS, and when we were coming out through the EBUS, we saw this metal head has left inside, but needle was inside the scope. So I just took out my EBUS, then at that time we need to use the second needle actually, but this is an example, we are making a foreign body through the EBUS. In summary, multiple EBUS DNA needles are available. There is no clear-cut best needle. Each size and type may have a role in clinical situation depending on your clinical situation. Other thing which is important, the local availability of the needle, the operational cost, sampling location, and histopathological diagnostic requirements. And at the last, I would like to all you to please come and attend the 6th annual PACS meeting, which is on the 19th and 10th August, 20th August, which will be an academic feast for the postgraduates and everybody. Thank you.